In Canada, disabled people are one of the most underserved population in our healthcare system, not because the care doesn't exist, but because the system wasn't built with them in mind. Today, I'm talking to Aruna, and Chloe, who are doing something about it. Welcome.
Thank you for having me.
Thank you for coming on the Hidden Shift. Chloe, tell us who you are and what is the Proud Project is all about.
Okay, I'll try. I tend to be long-winded, so I'm going to try and be short. I'm actually a professor. I have a Ph.D. in political science, but I do stuff around health equity and around disability and employment equity as well. So one of the things I'm really interested in right now is actually how we think of disabled people and people with chronic illnesses. So one of the things to think about is, for instance, the Center for Disease Control did a study in 2018. They asked 18 to 35-year-olds about their health, and 52% of them identified as having a chronic illness. So right now we perceive in society and also in the clinic that really the disabled are at most 1 in 6 people. But if that is the case, and I'm sure that's medicalized, we've medicalized ourselves a bit, but if half of an 18 to 35 population, which is your prime of life, think of themselves as having chronic illnesses, then we are really a society in which we're going to have to navigate this a bit better. And so I'm, for example, I have a disability. It's episodic. I have a complicated illness. People wouldn't know it, but I work and I'm in the clinic as well. And the clinic is not set up for disabled patients. It's better than it used to be. For instance, I was saying to Aruna today, I was at a clinic and all of the examination beds were electronic. So yes, I could have transferred out of a wheelchair onto one. Couldn't have done that years ago. But the other part is that we're not really thinking that healthcare providers actually may have disabilities as well, or chronic illnesses. And the Proud Project right now has done, we've done multiple projects, but the latest one we've done is around employment and disability. And we've looked at 5 countries: Canada, the US, the UK, France, and Britain. And one of the things that's really important is that disabled people receive health care that they are sort of maximally healthy, or they have control over their sort of physical and psychological health. And then in that sense, they are best able to interact with the rest of the community. And I'll hand it over to you.
Yeah, same question to you, Aruna. Who are you and what's your role in the Proud Project?
Thanks. My background is in occupational therapy. I graduated from the University of Toronto, and I've worked in a number of different areas with individuals that have disabilities as a result of stroke or being in a motor vehicle accident, having a brain injury, so in a variety of different ways, and also older adults as well with frailty. And so I've been a clinician, but more recently I've been in senior leadership positions in healthcare in Ontario and in Alberta, focusing primarily in the areas of rehabilitation. And right now I'm working with the home care program in a senior leadership capacity. So I'm very familiar with sort of the condition or the situation of people with disabilities in a variety of different ways, at a system level and also at the individual clinical level.
You should tell them what you did for Proud in the past year with regard to one of our projects.
So with regards to the Proud Project, I'm a co-executive director with Chloe for the project. And one of the things that we did is we worked with the University of Toronto Occupational Science and Occupational Therapy program to provide a clinical placement for students. And it was one of these unique placements. And we were interested in looking at accessibility, physical accessibility, primarily in environments that are specific to different communities. The idea is that looking at accessibility from an inclusive perspective and also an intersectional perspective. And so we had the students designing assessments or survey gathering tools of areas, businesses, communities, and we did a particular area in Toronto, the Gay Village at Church and Wellesley. and had the students going into different businesses to identify areas where there was accessible features and also where there wasn't. And the idea is to create a map so that people will have access to information at a granular level about what the environment is like. So when they want to plan to go somewhere or do something, they have much more information than they currently do. Right now you might have the address and you might have whether they have an accessible washroom. That's sort of it. There's no sort of standardized way of gathering that information. So we worked with the OT program with the students to not only talk about accessibility in terms of the physical layout and the dimensions and all of those sorts of things, but also talked about inclusivity in terms of people's lifestyle and what they want to do. And so in that particular environment, going to a strip club or some sort of a bar or into the gay archives, for example, you're going to have people with different lifestyles and conditions that may impact on their ability to really fully engage in community. And so that's one of the things that we did as part of the POWER project.
I'm just going to quickly add to that. What I mean by granular is, for instance, lighting. Like, for instance, if you have a vision impairment, there is no way for you to know what the lighting's like in an environment. If you're in a wheelchair, you have no idea what the texture of the floor is, which way it slants, or how heavy a door might be. You might be able, for instance, to walk a little bit of a distance. You're dropping your father off who has cardiac problems.
Yes.
What we were hoping to map is actually there's a perch spot 25 feet in from the door that he can wait there. You now know that as you park the car, there's somewhere for him to sit while he waits for you. So that was the type of granular detail that's not considered usually in terms of access.
Okay, so now let's take a deep dive into the reality of disability in Canadian healthcare. So I'm looking at you, Chloe. When we talk about disabled patient in Canada, what does the healthcare experience actually looks like day by day?
So I should preface this that I have, in some ways, it's a gift. Some people might not think so, but my disability, I can pass as able-bodied as I am today, or I can be a total quad, I can be vent dependent, and I can't see properly. And so I can't move, I can't speak. And I'm using a power chair or even a manual chair. So my range is wide in what I might need in an environment. And when you're entering a healthcare environment like that, the spaces aren't big enough, right? So, and that's expensive. In big cities, none of the hospitals are not designed with spaces, for instance, for accessible. There are now accessible washrooms down the hall, outside patient rooms, but they're not designed within patient rooms anymore. The examining tables, it's rare, though it's becoming increasingly common, that you can actually be transferred or transfer onto an examining table. For years, I was never physically examined by a physician because there was no means to do it other than me just sitting in a chair. So I think there are problems with, as you said at the beginning, that it's not really even considered. And I think one of the things we also need to consider, and this is happening increasingly, is that people with disabilities are now in clinical fields. So they may be an OT, they may be a physician. And in fact, so if you start to build all of the spaces with that in mind, then you're going to have spaces that actually work for everybody.
Thank you so much for sharing. And Aruna, you've worked on the ground delivering healthcare for disabled patients across Ontario and Alberta. What is the gap in the system between what the system think it's providing and what patients actually experience?
That's a very interesting question, and the answer is not simple or easy to communicate. I think, when I first started working as an occupational therapist, working with people who had disabilities as a result of their medical condition, the access and the awareness in the community was very, very limited. And it was really sort of an odd situation when someone now had to be in a wheelchair. And so you didn't see people on the street who were able to access environments using different mobility devices, for example. I think over the last 30, 40 years, things have really changed. And I think there's been an effort in the healthcare system and in society generally to be a bit more open to people with different abilities. And that's in part because of advocacy and different ways of understanding our daily living, and that we all have there's variety and difference on a number of different levels. In terms of the gaps, I think that, there's always going to be a gap between what people need and what's available in terms of resources. So I think there's a will and there's a desire to help support people in the community, to live in the community as long as possible, to not necessarily only have as an option moving into long-term care or some sort of supported living. But to what Chloe was saying, in terms of homes, people may want to have their loved one live at home, but it's physically very difficult to do. And it's also very difficult to get the level of care that's required. And it's expensive. And so sometimes people have no other option but to move into a care environment. And really people, if you really ask them, they don't really want to live in a congregate care environment, but they really don't have the option, or they don't have the understanding of what can be done to make their place accessible.
And on that note, making place accessible, is it something that's refunded by the healthcare system?
There's very little funding overall for making a private environment accessible. There are programs and grants and those kinds of things, and there are organizations that will help to fund, but it often is tied to what type of, whether you had a motor vehicle accident, the insurance company may pay. But if you have a stroke and you have the same disability, there's nothing that you can really apply for. And it's also tied to your income. Often it's related to what is the family income and whether you can access this this funding. So, and that information is not easily accessible for people. I think the big gap really, and this isn't just for people with disabilities, I think the big gap really is helping people to navigate through a very complicated system, whether it's funding or whether it's how to access resources or equipment. There's still a problem with that. I'll pass it on.
I'm going to add to this. So we did a study in 5 countries. And one of the things we found out in Canada, and this is a result of our federal system, is that there is no centralized way of knowing what you need to know as somebody with a disability or as a family who has a disability in it. And so that, I think, is problematic for us as Canadians because it's all delivered provincially. And so if you move a province, then the rules are different and your access is different and you never know exactly what you're getting into. Also, let's be really clear that healthcare is different than disability as far as the provinces are concerned. So once you're disabled, it's not the healthcare system's responsibility to provide anything to you. It's now sort of seen as outside of the realm of acute care. That's now something that's longer term and not really the responsibility of the healthcare budget to deal with. So it's privatized. Families tend to deal with it. But one of the things I've thought of is, in the end, I think it's cheaper for people to be looked after in their homes. We don't have to build, large infrastructure for it. But for example, I think it'd be very simple. Sweden's done this, which is that when you renovate a bathroom, there must be an accessible bathroom in every house. So if you're doing a renovation or you're building, you could build a tiny home. Nonetheless, your bathroom has to be accessible. And what this means is that if you break a hip, you now don't lie in a hospital bed waiting for a long-term or rehab placement, blocking someone from in Emerge who wants to go upstairs now is lying in a hallway. You go home because, in fact, your layout has been set up already. And so what we don't understand is that housing policy and bylaws like that, if we build communities that are more accessible, I think we will have less cost in our healthcare system, and we will see it as less of setting people aside. We tend to think, oh, I have a child with a disability, they're now going to be set aside because that's what we've tended to do. The point is, technology has meant so many different things. People wear eyeglasses. 700 years ago, they may not have worn eyeglasses, and those individuals wouldn't have lived a good life. So it's and somebody now, it's controversial for some in the deaf community, but they're cochlear implants. You may have a deaf child who in fact knows sign and English, becomes bilingual, and now has access to 2 communities and doesn't have to be sidelined. So I think there's this interaction between the technology that we have, which is advancing so quickly, and I think, and disability has actually been the driving force in it. So I'm going to say the remotes that we have, were originally made for televisions were originally for people with disabilities.
Yeah.
So because they couldn't get up and change
Oh,
the
wow.
channels. The voice activation on our phones, I paid
Yes, the speech,
I paid $10,000 in the '90s to have it on my
speech to text.
speech to text, and now it's everywhere.
Exactly.
So I mean, it was started there. Anyway, so I'm just saying that there are things in which disability can actually be a driving
Yeah,
force.
and today
for,
doctors are using it every day.
yeah, exactly. For good change.
For
Anyways,
good change, of course,
Anyway.
yes. Many of the stories we share on Hidden Shift have something in common. Doctors looking for more flexibility, more control, and better ways to practice. That's exactly why Locum exists, connecting physicians with flexible work opportunities while helping clinics and hospitals fill real gaps in care. Locum, rethinking how doctors work. Oh, thank you so much for sharing a lot. I think you touched a lot about what like we spoke about how the system wasn't built with disabled in mind, and you explained to us and give us concrete example. And thank you for sharing that, which lead me to the next question: who falls through the cracks most often, and why? Aruna, go ahead.
Who falls through the cracks
Yeah.
most often, and why? I think people who are not able to advocate for themselves or have families or support systems to advocate for themselves, I think are people who fall through the cracks.
Yes.
I think the system is so complicated and it's so difficult to understand. Even if you have someone who goes into hospital who has a medical condition and therefore they're going to move into a different stages, then move to different programs throughout the system, it's not readily apparent to people what that actually looks like. And so people can't advocate. I had a family member recently who was in hospital after having some falls, and you know, how the team kind of looked at her was that this was her baseline, whereas that was not her baseline. She actually was a candidate for rehabilitation, but it wasn't really apparent to the therapists or the team. They were like, well, this is how you are. You're just going to go home now. And I said, hang on a second. This is my family member. I know that there's some opportunity for improvement. Can we at least apply to a rehabilitation bed? And if I hadn't advocated for that, that wouldn't have happened. And people try to educate themselves, and they try to get information that will help them to move forward. I think in many ways I think the system is trying to narrow that gap a little bit by providing care at a very much a community level, particularly in Ontario. But it's a big hill to climb on, and I think that's one of the populations where, and this could be, it doesn't matter about income level, it's really about understanding how to advocate and how to, in some ways, challenge or question what you're being told. And I think that as the population moves in terms of generations, people are much more willing to ask questions. They can search on media about different conditions. They have a little bit more information about how to ask for details, which people wouldn't have had in the past. So that would be one population, I would say.
Wow, I think you want to add something.
I'll say this, is that one of the risks are, and I think it's part of the practice of medicine in itself, is that when all of us go to the doctor, we go for a fix, right? Something's wrong. We have a sore throat, our eyes are like spewing gunk or whatever it is, right? And we want that to stop. And so I think part of one of the difficulties around disability and health is that there isn't necessarily a fix. So there is a prejudice, and there's been a number of studies. If you ask physicians, they just presume that if you don't have a leg, you can't walk, your quality of life is bad. And so one of the things that people, if you can't advocate for yourself, one of the way medicine works is to fix. The thing that we have to step back and realize is that we may not be fixing things absolutely, but we now are able to allow people to live with all sorts of conditions, and they live quite happy lives, right? Contented lives. And it's that barrier that we sort of have to get over, that attitudinal barrier that can get in the way of people's care. And people don't realize that there's a barrier happening. So a disabled person may not be referred to intensive care because, oh, well, they don't walk. Well, they don't walk normally. So this is not a change. They actually, are a lawyer and work downtown. So yeah, they should be going to intensive care. So there are things like that I think we have to, again, it's about how we think about people and how they perform.
And now let's kind of focus on the innovation and advocacy landscape. I want your honest take on what's working and what isn't. So now let's kind of bring it back into the positive side, and where is the Canadian healthcare genuinely getting things right in terms of disability inclusion?
Well, I think actually, as I said, I think it's improved enormously in the last, I'm old, last 30 years, we'll say. And so that there is much more consideration of somebody who comes in with a chronic illness that you, in fact, might know more than the ER physician who may have seen it once or twice, but has never actually, may have seen it just sporadically, episodically in their ER, and not seen it at the development or the stage that you're at. And so in that sense, I think the healthcare system has done a lot, and I think it's done a lot through education, probably, and clinical education.
Speak about your own experience, in Ottawa, where they turned to you and said, you're the expert on your condition.
Yeah, that's true. I so recently, no, in the last year, I was quite critically ill, and I suddenly had 3 physicians of 3 different specialties who just looked at me and said, what do you do in this situation? And we very sort of, I had my son there, and we very clearly sort of laid out, okay, we take this medication, we take that medication, this is what we do. And they followed it. They just sort of said, all right, you're in the lead. And it did help. It did, the fact that we worked as a team, it felt very much as though we worked as a team. And as a result, in the end, we were quite successful. So I don't think that would have happened probably 15, 20 years ago, but it very much happened with this team.
And let's talk about the proud project angle, because that's kind of like that's your hidden shift, right? Chloe, tell us more about the approach Proud takes. Why research and advocacy together?
So, as you may gather, I sort of have a funny bent. Is that first of all, I think if you're a healthcare professional, you know this, or you should know this, that research, it takes 7 years for research to make it from wherever the research is done to the clinic. And that really is too long.
Yes.
And particularly for a vulnerable population and a disadvantaged population like disabled people, they can't wait 7 years, right? That they have a lot of difference. So one of the reasons we do research and advocacy is when we find out something, we want to first, I try and make sure that we deliver our knowledge that we've learned in policy environments so that people with policies are aware of what we're doing. The other part around health equities, the last publication I did was in CHEST, and I wrote with a colleague of mine, and we were talking about, for instance, how you allocate critical care and why disabled people might not be being allocated critical care because of sort of a hidden prejudice in some of the tools. And there, again, I'm trying to get across to people who deliver care that individuals who seem may not worthy of their attention or of their rescue are in fact worthy of rescue. I don't.
And how about you, Aruna? Your background in the healthcare delivery. What made you want to work on the advocacy and research side?
I think my background and interest in healthcare is driven by advocacy. I think it's always been there. And I think the fact that I chose to go into a profession, which 40 years ago, people didn't understand what the profession even was. So we were automatically having to advocate all the time for how occupational therapy specifically could be supportive or helpful in a particular situation, advocating with doctors, advocating with families, patients themselves, the government, in terms of funding or resources and that sort of thing. And I think that's one of the reasons why I moved into leadership roles, because I saw very quickly as a clinician that there were gaps in the way in which that could be addressed more at a system level than at an individual patient or client level. And so I've always been interested in that kind of advocacy tied with care. In some of my master's education, I was very interested in the care relationship between the care provider and the care recipient, and that it's an unbalanced relationship. It's
Yeah.
not an equal relationship. And so, what does that dynamic lead to the outcomes? So, I think that research and advocacy and care need to be kind of in the same space, as opposed to it's a very separate environment. And so I know pure research, when you're talking about labs and that sort of thing, it's a different thing. But I think there's a lot of research that's happening about quality of life, about how to improve people's and give people opportunities for inclusion. And as Chloe says, inclusion in community is something that, as a rehabilitation professional, is the core tenet of our discipline. And so what I have seen in terms of what's changed is that there is more of a recognition that you cannot care for a patient with a chronic illness or disability as an individual clinician, that you need a team. And the team needs to include a variety of different disciplines who can bring together their expertise. And so I've seen a lot of change in that area. So advocacy and being involved in Proud, as you can see, the range of things that we're trying to do is quite broad. But the underlying, I think, tenet of it is that, inclusion is something that is, it's a fundamental right. It's a fundamental part of who we are as people. And whether you're advocating at an individual patient level or you're advocating at a senior level in terms of program development or what services are put in place or how to organize the services so they're efficient and effective, which is something that I like to do, I think that makes a difference.
Wow. And last question, and if we can reply really quickly, and we'll start with you, Aruna, what do you want a healthcare professional, hearing our podcast Hidden Shift today, to do differently starting tomorrow?
In terms of what healthcare professionals can do in terms of improving the care and the approach to people with disabilities, I think specifically, is to take a moment to understand who that person is and not necessarily see them as they are presented to you. And, I think it's important to, and it's better than it has been in the past, finding out what's important to the person. What do they want to be able to do? What do they need to be able to do? And what supports do they need? Because oftentimes I think we make assumptions about what people would want or where they would like to be cared for or what care they even want or don't want. And I think that we have to see people as people and have different appreciation for inclusivity, which is often driven by people's culture and their experience, their education. And so you do need to take that extra moment to not just see somebody as somebody through their lens of the diagnosis or what they appear to be, but to really understand who they are. We used to call that client-centered practice, and it really is putting the person at the center in really knowing what it is that
so they can feel
want.
seen and heard.
Seen and heard.
And
exactly.
how about you, Chloe? What do you want a disabled Canadian listening to this to know today?
I thought you were going to ask me about a healthcare professional. Can I answer the first one?
Of course.
Okay. So what I would really like to do, I think, would change things, is actually for a clinical team to turn around and look at themselves and say, okay, who here needs accommodation in our team? What do my team members need in order to be more productive? And you could have someone there who has depression. You could have someone there who actually's got an elderly parent and needs to, leave every Friday at a certain time. Or you could have somebody who actually says, like, I've got diabetes, I've just been diagnosed with it, I need X, Y, and Z. I think if we begin to think of patients not as other, but as a part of humanity of which we are an integrated part, that then you don't get this top-down view. And so that, if you think of it can be dangerous to think of yourself as totally only helping others and that you yourselves don't need assistance and accommodations.
Thank you very much, both of you, for sharing today. And that was the Hidden Shift. The system wasn't built with everyone in mind. Chloe and Aruna are working to change that. One study, one patient, one policy at the time. It was Dikonguè for the Hidden Shift.